Hi everyone, how are you? It is Dr. Splichal, functional pediatrist, human movement specialist, educator through EBFA Global, and founder of Nomboso. So we are going to talk about pediatric flat feet and the million-dollar question of, do children grow out of flat feet? So this is a really important topic because if you misappropriately tell a child who has a certain type of a flat foot, you'll just grow out of it, and they actually have a certain foot type that they won't, you could potentially be impacting this child into their adulthood. Now, there is a difference between what is called a pancake foot, or what I call a pancake foot, and an actual overpronated foot in a child, pediatric pes plano valgus. I'm going to show you real quick what a pancake foot looks like and really what that means to a child. Okay, here we go. So pediatric flat foot, we are looking at what I call a pancake foot. This is an itty bitty baby, but you'll get an idea. So this is a child who has no arch. Here's another picture of a child that has no arch. Granted, these are probably 12-month-old feet, maybe 18-month-old feet. But it takes until the age of 10 years old to develop what will be reflective of the adult arch. So I had a patient that I saw yesterday who was referred to me for toe walking. And I spoke to the parents and they said that they are looking for a second opinion because of them exhausting all of the physical therapy and correctives, foot strengthening for their child who's a toe walker, and they're scared that the only thing that is left is going to be surgery. So I met with them yesterday, and this is the child's foot. So this is her standing. She's 7 years old, and this is her standing on the ground, both feet. Now, as soon as I see a child that is standing on both feet in what's called relaxed calcaneal position and has a severe overpronation. So this is not a pancake foot. This is an overpronation element that is creating more of an impact higher up in the body. So not only does she have calcaneal valgus bilaterally, but she also has, if you look at her midfoot, do you see how the midfoot is collapsing? She has navicular drop, and she has what's called a talonavicular uncovering. So that uncovering of the talus and the navicular is really important when you're grading severity of overpronation or quote unquote flat feet. As soon as you start to get into this rotational overpronation, midfoot collapse component to a pediatric foot, totally different ball game. We need to be thinking about this very different than the traditional strengthen the foot, strengthen the glutes, get into minimal shoes, sensory play, things like that. That is still a component, but we need to be taking a little bit deeper dive into other aspects of this foot function. So one thing real quick, when we look at the foot like this, what you should be thinking is tight ankles. So oftentimes you will see a pediatric flat foot, overpronation, pediatric pes plano valgus in association with what is called Aquinas. Now, pediatric Aquinas specifically, Aquinas means limited ankle dorsiflexion, limited ankle mobility, okay, but to a clinical degree. Now, there's a few different causes of pediatric Aquinas. I'm going to go into those briefly. So the first one is congenital gastroc Aquinas. So congenital gastroc Aquinas, which means that the connective tissue and the fibers and the fascia of the gastrocnemius is structurally short, structurally tight, has less elasticity in it. Another type is a congenital gastroc soleus complex Aquinas. So now you have more of the fibers of both the soleus and the gastroc forming more into the Achilles tendon that is causing that Aquinas. Another big one that some people thought of when I posted the video of this little girl walking was something a little bit more neurological, and that is a spastic Aquinas. Now, typically a spastic equinus is going to be associated with more of a upper motor neuron condition. So thinking cerebral palsy, muscular dystrophy, hypertonicity. Sometimes you'll see it in autism and ADHD and things like that. You see spastic equinus in adult upper motor neuron issues, status post-stroke, MS, Parkinson's. So you can see kind of that neurological side. Now, a spastic equinus has a hypertonicity to the posterior group. They're almost on a clonus or this clonic type contraction. And when you go to move the ankle with a spastic equinus, so this is the foot, I'm dorsiflexing the ankle. You'll hit your end range of motion. You'll feel the muscle resistance pushing down because of the spasm. And then if you hold the resistance, eventually it'll just kind of give way. So it's kind of this classic presentation of that spastic equinus. Now, the fourth type, which we see a lot, is a secondary equinus associated with a flexible pes plano valgus. What this means is that oftentimes, why someone stands, child or adult, stands like this is because of limited ankle dorsiflexion. This is their compensation, but their compensation further tightened the posterior group and is perpetuating this compensation pattern of going around the ankle, pes plano valgus eversion. So that is kind of a secondary one that you often will see in conjunction with congenital gastroc equinus and things like that. Okay, so now here right away, we know that she has limited ankle dorsiflexion. She has pediatric equinus. She did not have a spasticity, so she had normal range of motion. Now, why she's standing like this on the ground is because she has such limited ankle dorsiflexion that she can't even stand on the ground without pronating. Let me explain that again. So in order to stand on the ground in a neutral position, you need at least 0 degrees of ankle joint dorsiflexion in neutral. So if we cannot find subtalar joint neutral, right, or slight valgus, right? Are we ever fully in neutral? This is not the point to have that argument, but to have a ability to find 0 degrees dorsiflexion. So that 0 degrees dorsiflexion in neutral is what is needed to stand flat on the ground on both feet. This is telling me that she does not have the ability to achieve 0 degrees dorsiflexion without compensating. And the way that this was evident is that I put her into an open chain position. And then when she was open chain, I looked at her range of motion. So this is how you would look at ankle joint dorsiflexion open chain. I typically hold the subtalar joint into neutral in this position. Now, when I did that to this little girl, so this is her ankle, right? And she was in neutral. She was in this position. That's as much dorsiflexion as I could get in her ankle when she stayed in neutral. As soon as I let the foot do what it wanted and got dorsiflexion and she came up, she went boom. And she completely subluxed into her midfoot and her talonavicular joint. That is telling me that this is a structural imbalance in this child. This is a congenital equinus and is leading to a structural flexible pronation or pes plano valgus with a midfoot collapse. This is important to note again because it helps you to understand the correctives and the directions for that child. So open chain, she can't get to 0. Closed chain, the only way that she gets to 0 so she can stand on her feet is she has to compensate through a rear foot pronation and a midfoot drop. She also had flexibility or a hypermobility to her midfoot or medial column. Now let's go through the rest of her foot assessment just so you can see the way that her foot is moving. I always start in the bilateral stance, and then I take the child into, or the individual, into a single leg stance. So here she's in a single leg stance, and you can see what I want you to note is that, do you see that even on a single leg, that this is considered active? This is her active calcaneal position. Her midfoot is still dropped down. That is telling me that this is a more progressed compensation pattern, and she has some of that instability. I would also start thinking that maybe she has an accessory navicular, which could be oftentimes apparent in this foot type as well. Now, the third thing that I have the patient do is after they do a single leg stance, they do a single heel raise. So do you see that she can get into a push-off position, which is great. She's actually doing a really good job across her met heads. Awesome. I would like to see a little bit of more inversion in that subtalar joint, but not bad. Let's take a look at her left side. So her left foot, same thing. So on the left foot, you can see also, and the camera's a little bit angled, so I do apologize. So you can still see the eversion in a single leg active position. Her midfoot is still collapsed, right? So as far as this is how she's going to be going through mid stance in gait, okay? That's important to understand because of this orthotic decision to orthotic or to not orthotic, okay? And then finally, I do want to show this because this is a great point. So this is her doing a single heel raise. Now, before you freak out and you think, oh my God, she does not have enough dorsiflexion of her first MPJ, this is a moment in time. This is a snapshot. Anytime you see an image on social media or on the internet, it's a snapshot in time, right? This little girl was trying to find her balance. She wasn't holding on the wall. I kept telling her to hold the wall. She's being silly, right? So she just lost her balance. So that's what I want you to understand from this as well. All her other repetitions, boom, she hit that lever. So let's make sure that we don't read into some of the images, because if I showed that, boom, everyone would freak out, okay? I also take single leg squats or with a grain of salt as well, because you never want to do a repetition of a single leg squat and then make all of your conclusions. All right, so here we go. Let's see this little girl walk. Now, remember that I was referred to her as a toe walker. Now, if you just see her standing like this, you won't know, is she a toe walker or is she not a toe walker? Because toe walkers typically have a spasticity or a hypertonicity or a structurally short posterior group or an Achilles tendon. And if they have idiopathic toe walking, not all toe walkers have an actual upper motor neuron neurological condition. You can have someone who's otherwise healthy, has no other neurological conditions, and they still have this idiopathic toe walking, which is why it's called idiopathic. So just looking at her feet, haven't seen her watch yet. I'm told she's a toe walker. I'm expecting her to be a toe walker. So let's watch her walk. Okay, and I'm going to show you the camera and then let you just watch for a moment. Okay, so here now she's just being silly. I told her to walk faster, right? And then I had to tell her to slow down because she kept being so silly, right? So that's part of the pediatric gait. Okay, she's going to come back one more time. Okay, now if you're like, I don't know what I saw, right? What you want to think of is she actually toe walking? That's what I wanted to see. Watched her walk and I was like, I'm not that sure. Let's look at this slow motion because the naked eye has a hard time capturing this sometimes. So what I do always when I film people walking is I then want to find that moment in time. So let's see, a moment in time. Sorry. Trying to find my moment in time for you guys. Right there. Okay, here we go. Do you see her foot? Do you see her heel? She is striking her heel. So this child, especially on her left foot, is not a toe walker. She has heel strike. So then my goal is to go to the right foot and find that exact same moment in time. Let's see if Emily can do it. Here we go. I looked at her other foot and boom, there you go. She is a heel striker. Now, so this is great. This is huge. So I'm telling the parents, oh my gosh, you guys are thinking that you have a toe walking child, and I want you to feel confident and rest assured that your child is actually not a toe walker. What she is doing, her compensation when she walks is she actually has an early heel lift. So it is one of the other compensations, a less severe, let's say, or a less apparent in your face compensation for a Aquinas or a limited ankle dorsiflexion. So let's take a look at that. And let's see if your eye can capture that early heel lift now that we have a perspective. Okay. So what I want you to look for is every time she takes that step, she has this rapid pop of her heel. She's going to walk away. One more time. Okay. Now I'm going to show you it with her shoes on, because oftentimes it's a little bit easier to see with the shoes on. And actually, let me make this bigger for you. Hold on there. I'm going to blow this up. Okay. Do you see right there? So that's probably where you got the best perspective when she was walking away. Okay, so now she has that early heel lift. It's a little snap that comes off. Where this becomes an issue with adults, early heel lift, with athletes, the way that I think of the early heel lift is that it is kind of a energy leak in a sense, that your center of gravity when you walk kind of moves like this sinusoidal rhythm. In someone who has an early heel lift, there's this rapid uplift of their center of gravity and this drop. So they have a much sharper switch or amplitude to their gait pattern and that sinusoidal pattern. That's an energy leak. And that's a way that you can think of this if you see this in adults. Now, for a child who has an Aquinas, the structural Aquinas of that posterior group, right? It's structural here. It's in the connective tissue. And then as soon as we go into that 90-degree angle or that 0 degrees dorsiflexion, she's subluxing into her talonavicular joint. She's uncovering it, which is starting to cause this midfoot pronation. So what do we do for this child? If we just stretch the calves, if we do foam rolling and massage, are we going to get sufficient range of motion in that posterior group? Majority of these cases, she's 7 years old. She can stretch, she can splint until she turns purple, and she's probably not going to get to a neutral 0 degrees dorsiflexion. That's important to understand because you don't want to make sure that, or you want to make sure that these parents are not making these children stretch to nauseam when you're really not going to get to a 0 degrees or positive ankle joint dorsiflexion. And then her compensation is a midfoot collapsed pronation with a talonavicular uncovering. So then that goes to your million-dollar question. Should you use orthotics in this child or not? I am actually very aggressive or quite aggressive in orthotics for children. So the orthotic that you would want to use in a pediatric pes plano valgus that is caused as a compensation from a congenital gastroc equinus or a secondary gastroc soleus equinus from the pes plano valgus, all we're talking about is structural here, is called a UCBL. Now a UCBL, I will show you what that looks like, kind of like an aggressive version of it, but you can see here. Right, do you see that shell of an orthotic? Now the UCBL, it's a very specific, it's a pediatric orthotic, and it has these walls that come up on either side. Because children's feet are so flexible and they're still developing and there's a lot of cartilage, you really want to almost cup that rear foot and the midfoot along the medial and the lateral column. And that's what it's doing. That's what a UCBL is. Now the UCBL is acting like a wall to prevent or to decrease, minimize, mitigate the amount of talonavicular uncovering that is happening when this child goes onto the ground. That is something that is important when you are thinking of laying the foundation through which the rest of the bones, tendons, nerves, and blood vessels are growing. Now, typically when this child becomes maybe around like 10 years old, you want to switch from a UCBL and go more into a traditional orthotic with a flange or a wall on the side of it. So what I recommended for these parents was, first, I reassured them. that, again, they do not have a toe walking child. They have a child who has limited ankle dorsiflexion and overpronation, not a pancake foot, not flat feet that they're going to grow out of. This is something that's structural. So how do we manage this? How do we manage this? Okay. We do want to focus on ankle mobility just so you maintain a little bit of balance. But again, don't do it to nauseam so that this child creates a negative association to movement or therapy or something like that. I told them that if they are going to do it, doing things kind of in playtime. I'm much more a fan of SMR and vibrational based SMR. So I told them to get a roller that has a vibration component. And then when the little girl is watching TV, she can just rest her posterior group or her calves on that vibrating roller. And then it's kind of fun, right? She can do that. And then if she does any stretches, this is really important because the little girl showed me the stretch that she did, and she was doing the one where you lean against the wall, and I'll show you that. So if you're doing a calf stretch against a wall, kind of like this, right? This is what the little girl showed me that she did. Now, if she does this barefoot, and she goes to stretch her calf and she leans and pushes into it, she is essentially pushing into that overpronated position, which means, is she actually getting any Achilles or gastroc or posterior group lengthening? No, not at all. There's some awesome research studies showing this, that if you have a midfoot collapse and you stretch your calves in a midfoot collapsed foot, you do not get any stretching of the posterior group. You actually put tension on the posterior tibialis, and this girl's foot is susceptible to a post-tib tendinitis. So we want to be very careful about that. So I said, you know, Mom, Dad, when you do that wall stretch, if you're going to do that with your daughter, she has to be in her UCBL and her shoes. Okay, so we can control the foot position to make sure that we're actually hitting the muscles we want to hit. So vibration roller, get a little bit of inhibition of that posterior group, and then do a little bit of a stretch. Again, but don't stretch like crazy because you're not going to get a massive increase in dorsiflexion. She could do the Theragun to get a little percussive therapy, things like that. She could use a rad rod or something to massage down and make it a little bit like a game for the child. Continue the UCBL. Again, the UCBL will be very important. What I did say, though, is to put the UCBL, continue it in a minimal shoe, such as what that child had on. She had kind of a minimal Merrill shoe for a child. Continue that type of shoe because we want to keep the cushion out of the shoe, keep the wide toe box. The flexibility of the shoe is still good for the other aspects or the other benefits that that provides. If you put an orthotic in a minimal shoe such as that, you absolutely can. But what I actually see is that you can crack the shell of the orthotic easier. So they had come in with that UCBL and it was cracked. And they're like, like they kind of keep cracking on her or the shell breaks. And the reason it's breaking is because they're putting it in a flexible shoe. As long as they're fine with it, you'll just have to buy another one. If they put the UCBL in a thicker cushioned structure shoe for the child, I said that that child is going to kind of walk around like they're blocks. Right? So these are like cinder blocks that she's moving, and I don't want that for children. So that's kind of the middle ground. Continue doing foot exercises. This is really important, but are those foot exercises going to change the shape of that foot? No. Does that mean that you should not be doing them? No. There is a benefit to strengthening the foot that exceeds just, I do foot exercises to build a foot arch. Sometimes you cannot do that, and that's really what I focus on through my education, is understanding that differentiation. Okay, fourth is sensory, 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 sensory. So get the Naboso insoles, put the Naboso insoles on top of this UCBL. Get her barefoot still. She should be able to play around barefoot, get on textures, climb the trees, do whatever be a kid, right? Be a child and be sensory rich. So that's a huge part of it as well. So don't be married to the UCBL and the shoes and the sneakers and all of that, the support. Okay. And then I said, you really do want to start to create foot to core sequencing in the child in in children, pediatrics, because our core and our glutes are so deeply integrated to our feet. And when you have overpronation and a midfoot collapse, obviously that's going to stretch your knees, hips, and lower back, just like it does in adults. Now, foot to core sequencing in a child is very different. Kids don't like doing standard short foot and do 10 reps of calf raises. Children don't do that, right? We have to make it play. So I said that if she goes into dance or gymnastics, things like that are really good for her to understand how to build body awareness. So in children who have feet typically like this, what brings them into the pediatrist a majority of the time is the parents are concerned because the child keeps tripping. So they'll say, I don't know what it is. Can you please look at my child's feet? Why do they keep tripping over their feet? Right? Or they get tired, or they constantly want to be carried. That is something that you always want to ask the parents. And I asked this little girl, I said, do you trip? And she said that she does. And then you want to ask kind of how often is it, right? So things like that. You can ask them, do your feet get tired, right? Where do your feet get tired? Do your calves get tired, right? And this little girl got really tired calves. As soon as she stands too long, her calves get tired. She said she does trip. So all of that makes sense, right? And a lot of that has to do with decreased kinesthetic awareness as well around that type of a foundation. So that's why I like sensory play. And then I told them that you can kind of build up through different LA pads and kind of maybe she has some house shoes and you don't want to be in the orthotic. Can you find a less controlling environment just to kind of find this variety for them? Something really important. Now, how I want to end, just so that we have kind of a complete picture. So that was my patient, and that's the way I approached her. Those are the questions I asked. That's my evaluation. This is my conclusion and my recommendations for that patient. Okay. Now, if there's questions around that, of course, please let me know. Now, for other pediatric Aquinas that is causing toe walking, I want to go into that real quick. So if you have a true toe walking, this is typically a little bit more spastic, and I'm going to show you a video of that. Okay, I'm going to play that one more time for you, just so you can see the difference of how this individual is walking compared to how my patient was walking. Okay. Do you see how they're on their toes the entire time? Now, toe walking, same thing, past age 5. If this was how this 7-year-old walk, I would be having a completely different conversation with that parent, okay? And my conversation would be advocating, right? Depends if that child can get 90 degrees. If I cannot get anywhere near 90 degrees, if they stand passively and cannot even compensate to drop down, that's where you do start looking at surgery. Now, some of the other idiopathic toe walking that I will see is that if you do bring sensory, this is where we're doing a toe walking research study with Noboso. If you bring texture, vibration, things like that into an idiopathic toe walker, oftentimes they will drop down into a heel toe gait. So you want to see, how do they respond to sensory? If they do respond to sensory, that's part of your intervention. If they don't respond to sensory and they're staying in that toe position, you really do want to start exploring surgery. And what I tell the parents is think less about the, oh my God, I don't want my child to have surgery. And I want you to think of what is the potential ramification 20 years from now for that child, right? That's the way that we want to think of that. If we did an Achilles tendon lengthening and got them into a 90 degree, they would probably be moving like my patient did, which is much more manageable on the entire MS system than just staying on their toes, okay? So I hope that helps. And then last thing that I wanted to mention real quick is surgery. Can you do surgery for a patient like what I just showed you of mine? Now, the surgery for pediatric flat foot, there is a surgery because there's a surgery for everything. The surgery that you would do is it's called an arthrosis. And I will tell patients that it's almost like an internal orthotic. Now, the internal orthotic or implant, the arthrosis, so you can see right here, it's going into the subtalar joint. Now, the decision to do that on a pediatric patient is based off of the type of the flat foot or the overpronation. when you see it more so in the rear foot. So you have to have more of an isolated rear foot pronation that you are trying to control, because that implant goes into the subtalar joint. In my patient who had more of this midfoot uncovering, the success of that implant would probably not be that high. So for her, you would want to, I told the parents, just wait. She probably will need surgery at some point, maybe when she's in her 30s, 40s. I actually have a patient shortly that I'm seeing who had a flat foot reconstruction, who probably looked like this as a child. He looked like this as an adult. And he just had a reconstruction, and now I am doing a functional foot program with him to get him back to his baseline strength. Okay, so that's the way that we want to start thinking about this. I hope that this helped you to understand and be able to explain that million-dollar question of, do children grow out of their flat feet? And our answer is, it depends. Pancake foot, maybe, right? By around age 10, you'll be able to see. Overpronation with a midfoot collapse, we need to look at some intervention. To learn more about how I approach feet from a functional perspective, please visit my website, dremelysplichal.com. Follow me on Instagram and stay tuned for more functional feet education.